Someone join online?
Good morning, everyone. The topic of my seminar today is Psychiatry masquerading as neurology. My moderator is Dr. Sumit Mehta, sir. Defining neuropsychiatry. Neuropsychiatry is the assessment and treatment of patients with psychiatric illnesses or symptoms associated with brain abnormalities. How common are functional symptoms? Around 1/3 of the new neurological outpatients have symptoms regarded by neurologists as not at all or only somewhat explained by disease. Contrary to the popular belief, even the more dramatic functional symptoms are surprisingly common. Example, the incidence of functional paralysis is similar to that of multiple sclerosis. Non-epileptic attacks make up around 10 to 20% patients referred to the epilepsy clinics. And up to 50% of patients admitted to hospital in apparent status epilepticus. Why should we bother about functional symptoms? When patients with functional neurological symptoms are compared to those associated with disease, they are found to have similar disability and even more distress. Their symptoms tend to persist at follow-up, but only rarely explained by disease. These are the examples of some functional somatic symptoms and syndromes from different medical specialties. In neurology, we have functional weakness, non-epileptic attacks, hemisensory symptoms, gastroenterology, irritable bowel syndrome, non-ulcer dyspepsia, chronic abdominal pain, gynecology, chronic pelvic pain, premenstrual syndrome, ENT, functional dysphonia, globus pharyngeus, cardiology, atypical chest pain, unexplained palpitations, rheumatology, fibromyalgia, infectious diseases, post-viral, chronic fatigue syndrome, immunology or allergy, multiple chemical sensitivity syndrome. Now, functional weakness. In general, signs of psychogenic weakness and gait impairment compared to signs of sensory loss are more sensitive and specific and carry greater predictive value. Clues to some psychogenic weakness are non-anatomic distribution of deficits, sudden onset and variable presentation. If it is reversed during an interview while under the influence of hypnotic infusion or hypnosis, deficits that are intermittent. Motor weakness. Motor weakness can be tested by Hoover's sign, face hand test, and abductor sign. In Hoover's sign, described in 1908, it is the most useful test for functional weakness and indication for psychogenic unilateral leg weakness. Normally, when someone attempts to raise a genuinely paretic leg, the other leg presses down. The examiner can feel the downward force at the normal heel. Hoover's sign consists of patient unconsciously pressing down with paretic leg when attempting to raise the unaffected leg and failing to press down the unaffected leg when attempting to raise the paretic leg. For example, in this picture, a neurologist demonstrates Hoover's sign in a 23-year-old man who has a psychogenic left hemiparesis. In picture A, she asks him to raise his left leg as she holds her hand under his right heel. Revealing his lack of effort, the patient exerts so little downward force with his right leg that the neurologist easily raises it. When the neurologist asks him to raise his right leg while cupping his left heel, the patient reveals his intact strength as he unconsciously forces his left paretic leg downwards. As if to carry the example to the extreme, the patient forces his left leg downward with enough force to allow the neurologist to use his left leg as a lever to raise his lower torso. Face hand test. In this, the patient momentarily exerts sufficient strength to deflect their falling hand from hitting their own face, suggesting psychogenic paresis. For example, in this picture, a young woman with psychogenic right hemiparesis inadvertently demonstrates her preserved strength by deflecting her falling paretic arm from striking her own face as the examiner drops it. Abductor sign. This test involves abducting, separating the legs. Normally, when asked to abduct one leg, a person reflexively and forcefully abducts both of them. Someone with genuine hemiparesis will abduct the normal leg but will be unable to abduct the paretic one. In contrast, Someone with psychogenic weakness will reflexively abduct the paratic leg when abducting the normal leg. Gait disturbances. Features suggestive of a functional gait. Excessive slowness, dramatic delay in gait initiation and subsequent foot sticking without the subsequent improvements seen in extrapyramidal disorders. Falling towards or away from the doctor. Walking on ice pattern. The gait pattern of a normal person walking on a slippery ground. Cautious, broad-based steps with decreased stride length and height. Stiff knees and ankles. Arms sometimes abducted as if on a tight rope. Uneconomic postures with waste of muscle energy. A gait with an eccentric displacement of center of gravity, such as standing and walking with flexion of hips, often associated with fear of falling. Sudden knee buckling. Patients usually prevent themselves from falling before they touch the ground. Knee buckling can occur in Huntington's chorea and cataplexy. Astasia abasia. In Greek, it means inability to stand, inability to walk. In this disturbance, patients stagger, balance momentarily, and appears to be in great danger of falling. However, catches themselves at the last moment by grabbing hold of the railings, the furniture, and even the examiner, but they never actually injure themselves. Functional sensory disturbance. Although the sensory disturbance is the least reliable portion of the neurological examination, several sensory abnormalities indicate a psychogenic deficit. For example, loss of sensation to pinprick with a sharply demarcated boundary in the midline of the face and body constitutes the classic splitting the midline. This finding suggests a psychogenic loss because the sensory nerve fibers of the skin normally extend across the midline. For in this picture, we can all see a young woman with a psychogenic right hemisensory loss appears not to feel the point of a pin, which is used only for illustrative purposes on her right forehead. But when it crosses the left of the center, she immediately appears to feel it. That is, she splits the midline. In a variation of this test, because vibrations naturally cross the bony structures, loss of vibration sensation over only half of the forehead, jaw, or sternum strongly suggests a psychogenic disturbance. A similar abnormality is loss of sensation throughout the entire face, but not past the hairline. This pattern is inconsistent with the anatomical distribution of the trigeminal nerve, which innervates the face and scalp anterior to the vertex, but not the angle of jaw. Functional or psychogenic movement disorders. There are some general features common to all functional movement disorders, that is, rapid onset, variability in frequency, amplitude, or distribution may be obvious during an examination or during observation at other times. Improvement with distraction. Distracting tasks includes asking the patient to perform tests of mental concentration, example, serial subtraction, or physical tasks with their normal limbs. The inverse, worsening with attention, may also occur. Dystonia. Psychogenic dystonia is being recognized and is included in the spectrum of fixed dystonia. The diagnosis is difficult but includes features like an inverted foot, a clenched fist, a fixed posture, onset in an adult, which is apparently present during sleep, and the presence of severe pain. The gold standard for the diagnosis of functional dystonia is to demonstrate complete remission after general anesthesia or a placebo, such as a procedure may also be therapeutic. A high proportion of patients with psychogenic dystonia have had an injury to the affected limb. As in this picture, a patient with paraplegia and psychogenic / functional dystonia of 14 years duration before on the left and after on the right, after treatment with psychotherapy. Psychogenic myoclonus. It is described as a myoclonus with variable amplitude and frequency. It may be strikingly stimulus sensitive, for example, to fluorescent lighting or with elicitation of deep tendon reflexes, in which case the latency between stimulus and jerk is long and variable. Laborious research methods may demonstrate the presence of a Berettschaft potential 1 second before the jerk, whereas in cortical myoclonus of organic origin, there may be a cortical spike around 20 milliseconds before the movement. Non-epileptic attacks. Non-epileptic attacks or functional attacks or pseudo seizures have been broadly divided into hyperkinetic or thrashing attacks and akinetic or motionless attacks. There is a wide differential diagnosis for attacks that look odd. Strangeness in itself should not lead you to a diagnosis of pseudo seizures. Frontal lobe seizures can look particularly bizarre. Paroxysmal movement disorders are another potential catch. This is a table which shows attack features that can help to distinguish non-epileptic attacks from epileptic seizures. For example, situational onset is occasional in non-epileptic seizures and rare in epileptic seizures. Gradual onset is common in non-epileptic seizures and rare in epileptic seizures. Non-epileptic seizures are occasionally precipitated by stimuli, but very rare in epileptic seizures. Undulating motor activity is common in non-epileptic seizures, but rare in epileptic ones. Asynchronous limb movements are common in non-epileptic seizures and rare in epileptic. Purposeful movements are occasional in non-epileptic seizures and very rare in epileptic. Rhythmic pelvic movements and opisthotonus are occasional in non-epileptic seizures and rare in epileptic ones. Side-to-side head shaking is very common in non-epileptic seizures and rare in epileptic ones. Tongue biting at the tip is occasional in non-epileptic and rare in epileptic. Tongue biting at the side is rare in non-epileptic and common in epileptic. Prolonged ictal atonia is occasional. Prolonged ictal atonia, ictal crying, and closed mouth and tonic phase are occasional in non-epileptic seizures and rare in epileptic ones. Vocalization during tonic-clonic phase is occasional in non-epileptic seizures and rare in epileptic. Closed eyelids are very common in non-epileptic seizures and rare in epileptic. Convulsion lasting for more than 2 minutes are common in non-epileptic and rare in epileptic. Resistance to eyelid opening is common in non-epileptic and rare in epileptic. Pupillary light reflex is usually retained in non-epileptic seizures and commonly absent in epileptic. Reactivity during consciousness is occasional in non-epileptic and very rare in epileptic. Lack of cyanosis and rapid post-ictal reorientation are common in non-epileptic and very rare in epileptic seizures. In this picture, this young woman with a psychogenic non-epileptic seizure is screaming during an entire 30-second episode. Several features reveal its non-neurological nature. In addition to verbalizing throughout the episode rather than only at its onset, as in an epileptic cry, she maintains her body tone, which is required to keep her sitting upright. She has alternating flailing limb movements rather than an organized bilateral clonic jerks. She has a subtle but suggestive pelvic thrusting. Prolactin measurement. Serum prolactin is often elevated 15 to 20 minutes after a GPCS and should be normal after a non-epileptic attack. However, prolactin rise has been demonstrated after syncope and found to be normal after partial seizures. This test can be useful but is carried out badly in practice with no baseline sampling and a post-ictal specimen that is either measured too early or too late. For this reason, we do not advocate its use outside specialized units. EEG and video telemetry. This remains the gold standard investigation for non-epileptic attacks. However, patients with partial epilepsy, particularly frontal lobe epilepsy, may not show any abnormalities on surface EEG recording when there is a deep ictal focus. In addition, some patients may not have attacks during monitoring. Headache. A classification system developed by the International Headache Society characterizes headache as primary or secondary. Primary headaches are those in which headache and its associated features are disorders itself, whereas secondary headaches are those caused by exogenous disorders. Primary headaches often result in considerable disability and a decrease in patients' quality of life. Secondary headaches seen in association with upper respiratory tract infection are common but rarely worrisome. Life-threatening headache is relatively uncommon. In this table, it shows common causes of headache. Primary headache, the causes are tension type, migraine, idiopathic stabbing, exertional and cluster. In secondary headache, systemic infection, head injury, vascular disorders, subarachnoid hemorrhage, and brain tumors. This table shows classification of daily or near daily headache. Primary headache, more than 4 hours daily, which includes chronic migraine, chronic tension type headache, hemicrania continua, and new daily persistent headache. Less than 4 hours a day, chronic cluster headache, chronic paroxysmal hemicrania, and short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms. In secondary headache, post-traumatic head injury, iatrogenic post-infectious, inflammatory such as giant cell arteritis, sarcoidosis, Behçet's syndrome, chronic CNS infection, medication overuse headache. Differential diagnosis of a new daily persistent headache. Primary migrainous type or featureless tension type, and in secondary subarachnoid hemorrhage, low cerebrospinal fluid volume headache, raised CSF pressure headache, post-traumatic headache, chronic meningitis. Headache symptoms that suggest a serious underlying disorder. Sudden onset headache, first severe headache, worst headache ever, vomiting that precedes headache, subacute worsening over days or weeks, pain induced by bending, lifting, or cough, pain that disturbs sleep or presence immediately upon awakening, known systemic illness, onset after 55 years of age, fever or unexplained systemic signs, abnormal neurological examination, pain associated with local tenderness, example, region of a temporal artery. Other functional symptoms include dizziness. Anxiety and phobic avoidance of situations or head positions that bring on dizziness does not necessarily indicate a psychogenic etiology. Panic attacks presenting somatically with dizziness should be considered in the differential diagnosis of dizziness. Physiological vestibular sensitivity to particular visual stimuli such as patterned light or bright lines, sometimes called as visual vertigo, may lead to symptoms that also come on in crowded places. Depersonalization and derealization may be described by the patient as dizziness. If this sensation is present all the time, a patient may have depersonalization disorder, a chronic form of dissociation. A full assessment of vestibular abnormalities and emotional symptoms can lead to a tailored treatment in the form of vestibular rehabilitation or a cognitive behavioral approach, regardless of the etiology. Speech and swallowing symptoms, typically functional dysarthria, that is difficult or unclear articulation of speech that is otherwise linguistically normal, resembles a stutter or is extremely slow with long hesitations that are hard to interrupt. The speech may be telegrammatic, consisting only of the main verbs and nouns in a sentence. In its extreme form, the patient may become mute. Word finding difficulty is a common symptom in anyone with a significant fatigue or concentration problems and may compound a functional dysarthria. Dysphonia is a much more common functional speech complaint. Often the clinical presentation is of whispering or hoarse speech that is initially thought to be by laryngitis by the patient, but then persists for months or years. The possibility of a spasmodic adductor or abductor dysphonia must always be considered. Globus pharyngeus or functional dysphagia. Patients complain of a ball in the throat and investigations do not reveal a cause. Visual symptoms, intermittent blurring of vision that returns to normal if the patient screws up their eyes tight and then relaxes them again is commonly reported. Some of these patients have accommodative spasm with a tendency for the convergence reflex to be transiently overactive, either unilaterally or bilaterally. Voluntary nystagmus appears to be a talent possessed by 10% of the population. Patients with functional hemianopia have been described who have homonymous hemianopia with both the eyes open and then inconsistent with this have a monoocular hemianopia in one eye with full fields in the other eye. Auditory symptoms. Basic tests for deafness. So patients with functional hemianopia have been described who have homonymous hemianopia with both the eyes open and then inconsistent with this have a monoocular hemianopia in one eye with full fields in the other eye. Auditory symptoms. Basic tests for deafness rely on a startle response such as making a loud, unexpected clap out of sight of the patient. Auditory brainstem evoked responses or evoked autoacoustic emissions may be necessary to fully investigate a patient with this symptom. Investigations. Criteria for performing tests. Number one, we are uncertain of the diagnosis or the patient remains uncertain of the diagnosis even though we are and have done our best to explain it to them. If we are carrying out investigations to convince the patient, this may temporarily be effective in patients with severe health anxiety who can become addicted to the reassurance of investigations. Similarly, patients who are convinced that they have a certain disease like multiple sclerosis will not accept a negative investigation anyway. If the tests are abnormal and irrelevant, then positive functional signs should not be ignored and it may be necessary to make two diagnoses, one functional and one organic. My references are Kaufman's Clinical Neurology for Psychiatrists, an article by J. Stone, A. Carson, E. Sharp, and Harrison's Principle of Internal Medicine. Thank you.
There are a range of symptoms and patients which can present in neurology OPD, not only neurology OPD, but OPD, medical OPD, OPD, which are actually considered out, but not limited to this. There are even further range of patients still present in these OPDs. Questions and queries. The industry channel, a lot of questions would have raised, a lot of new machines.
I didn't understand who was and any on the PA. Can you
Yes.
explain?
Yes, sir, I'll explain. Yes, sir, I could have.
This very subtle level because it is very important.
Yes.
What is a normal? Then what, like in organic paralysis, functional paralysis. What is the difference?
Sir, in Hoover's sign, what we do is, so for example, a patient has a paralytic leg and an unaffected leg. So, sir, when the patient we'll ask the patient to raise his unaffected leg. So what we'll and if we'll hold the other heel of the patient, we'll feel that the patient will press down to raise his unaffected leg. The other leg will feel a force on the paralytic leg. But for example, a patient has a genuinely paralytic leg and he will try to raise it. So we will, on the unaffected leg, we will feel a force. But if the patient has a psychogenic weakness, he will not try to raise that leg and will not feel the force on the unaffected leg. That is how we differentiate.
But the Shani is still not clear. Again, repeat it.
Yes, sir.
What else can you
Yes.
clarify this? This is important. Examination also, and normally it is very useful in demonstrating whether the case is functional or say,
So for example,
normally if the patient we ask is patient lying down spine, raise one of his legs. So what normally will happen?
so when the patient will raise one leg, we will feel a force on the other leg, below the heel of the other leg.
Normal fulcrum. When we will try to raise this leg, if we ask to, normally this leg will be used as fulcrum to raise, get power in this leg. So this leg which is lying down will put force downwards. So this is the basic principle which will happen normally. Then now you can further explain if the it's an organic disorder or a non-organic disorder, then how will it? Normally we know a patient has been asked lying down supine to raise his right leg. By fulcrum, he will push his left leg downwards. This is the basic. Now go on.
So now if a patient has a genuinely paralytic leg, and if the patient has genuinely paralytic leg, so he will actually try to, when we'll ask him to raise his leg, he will try to raise his leg and we will feel the force. So, but yes, sir, on the unaffected leg. But if the patient has a psychogenic,
So this is clear.
yes, sir.
And if he tries to raise unaffected leg,
So we will force, if the leg is paralytic genuinely, we will not feel the force.
unaffected leg,
Then will not feel.
then will not feel
No,
the force
sir.
on the paralyzed leg.
No, sir.
Okay?
Yes,
This
sir.
is clear. Out of these two, which do you think is more, raising the paralytic leg or not raising the raising the paralytic leg or raising the normal leg?
So
Which is more,
raising the normal leg is more important.
raising the normal leg is more
Yes, sir.
important. Paralytic is to be mostly lower.
Yes, sir.
And then we come to functional paralysis.
Raising the, say, normal leg,
Yes, sir.
in that he will press
Press
downwards.
downwards.
right? In the other case, he will not press downwards.
No, sir.
Which one is more important?
But I think the most important thing is when he's raising the affected leg, because the normal, he will not try. Because he's not trying.
Yes, sir.
So
He's
even
not
a
trying.
paralytic person, so he will definitely try, and the normal leg will push down.
Yes, sir.
And in the dissociative case, because he will not try,
He will
then
not
it will not
try.
push
Yes,
down.
sir.
So in that way, I think.
And in dissociative person, then he will try to raise the unaffected leg because of this mechanism which Dr. Sumit is telling. The paralyzed leg will also get pushed up. The functional जहाँ पे paralysis है, वो leg counter push करेगा. Patient cannot have the control. So
Because it can't, not without pressing, it can't lift. या तो पैरेटिक वाला तो दूसरा ट्रीटमेंट दिक्कत होगी.
If say this is a case of functional right hemiplegia, it is non-organic, clearly functional psychiatry. Okay, so right is hemiplegia.
Yes.
If we ask the patient to raise his left leg,
Yes. Sir.
okay, then we will feel the force
Force on
below his right leg, which is supposed to have paralysis.
Yes.
So implying that there is no paralysis.
No.
Second condition, in the same functional right hemiplegia, we will
Yes, sir.
ask the patient to raise the right leg.
Yes. Sir.
We will not feel
Not
the force
feel.
below the left leg
Yes, sir.
because the patient is actually not putting any force.
Yes. Sir.
Consciously not putting any force, there is no fulcrum. There is no. So
then it is Dover's
positive.
Yes.
That is very clearly.
Here, medicine and neurology, if you go in medicine and neurology, it is more important for interns probably. You will diagnose in some way or the other. Okay, these guys will have other ways to diagnose. But you go in medicine neurology, you will miss the cases, you will start so many investigations, MRIs
And this is only this will work in functional monoparesis.
Yes. Sir.
And monoparesis, which is not very common. Generally, we say there is functional paraparesis. So in that context, and still Hoover's is not 100% sensitive. So even if you're not having it, that doesn't mean that patient is not having a functional issue.
Yes.
So you have to be critical about every sign. That Homo and if this is clear, I can put the second. I didn't understand this whole thing.
What is hemianopia first of all?
Sir, hemianopia is sir, either the nasal fields or the temporal fields of both the eyes are lost.
Okay.
Sir, it occurs due to lesions at the various parts of the optic tract.
Did you get what is written here? Last four lines?
The last 4 lines are
So it's
little difficult to understand.
I think
So I think what you're saying is if both eyes are open, the patient will report homonymous hemianopia. लेकिन जब आप एक आई का टेस्ट करोगे तो एक में उसको मोनोकुलर हेमियोनोपिया होगा और दूसरे आई का करोगे तो फुल आई होगा. मतलब लास्ट लाइन आई थिंक सो they are saying to say that you test the individual eyes.
वो यही है कि he is saying that my right side of vision is gone. So you test with both the eyes. So right side vision is gone. Okay. Now when you test individually, because this eye field is by both the eyes. Okay. So when you test individually, then with this eye, right eye, he will say that I can't see this side, but with left, he say I can see everything, which is not right. Because in homonymous hemianopia, you will have problem with both the eyes. It is central. It is not in the like eye itself. It is a central lesion.
So any problem which is ophthalmologic central, it will be bilateral. That will be binocular.
Somebody saying that I am just not being able to see with the right eye, and I am because if one eye is affected, then your field of vision, like this eye can see a lot of like temporal will be missed, but it is not right that with this eye he will not see anything because the field of vision will be more on the affected eye if it is bilateral, because both the fields they coincide, right?
So after deposition, any damage to the pathway will be binocular. It will be basically involving both the eyes. So that is what probably the
इसके लिए आपको पाथवे पता होनी चाहिए. हाँ, often like diagram ही होता था जैसे जाती है.
क्या tracts and क्या?
we see a lot of patients with tremors, psychogenic tremors. Out of all these few we have seen. So how to differentiate psychogenic tremor with a genuine tremor?
So genuine tremors would be present even while the patient is doing some work. Psychogenic tremors.
Did you come across psychogenic tremors in your preparation? We did not come across, right?
There is a test known as entrainment test, where patient is asked to actually mimic. Supposedly, patient is having a tremor in the right hand. Patient is asked to actually mimic from the opposite hand the same tremor which is happening in the opposite side. This is entrainment. So we're actually trying to entrain. And you'll see the tremors on the affected side will come down. But if it is a genuine tremor, it doesn't come down. Again, it is not 100% sensitive.
So can you go tapping movement with one hand, then it is intentional or bilateral. That also. And I think some days ago somebody presented that to check the tongue. It is very difficult to produce tremors in the tongue. That is also one of the indications. Because none of these signs is Dr. Shobhit Singh is like pathognomonic. You get one sign, if you say that it is dissociative and it is organic, that we should not. So we should have a battery of this thing built with the clinical history, behavior, etc. Then only we can say that yes, when in doubt, always err towards organic. That is even if when in doubt, always
Organic.
unless you are like.
And your very important second last slide. So that it can be an organic and a functional issue. I still remember 5 years, 6 years back, we admitted a patient who was admitted a few months before with functional issue. Subsequently, patient was walking very, like an aesthesia. We were considering aesthesia. Subsequently, found out that he was having a fracture. A trivial fall and a fracture. So because he was not examined. So again, this is and very a bias of us is if someone is coming with dissociation, we'll consider the person that we should at least think if there can be any other possibility. At least we should think of it. Similarly, someone coming with an organic, a genuine seizure, we feel that our second event can be a genuine seizure. Maybe it can be a partial seizure.
Many patients have both.
So you gave a chart. I wish you would have actually separated those points, very important points. So which you feel they are very, very important.
So
So
tongue bite.
comprehensive ticket, huh?
Sir, I feel tongue bite on the lip tip and the side is important. Close diamonds.
Again, as we have been saying, no single point is right. You must know a lot of these and include say chromatin level, say EEG, which is not in this level.
Yes.
So
Is history reliable?
Yes, history.
History,
Sir,
even in
good semiology.
so when we ask guardians history, first of all, if guardian has not observed it, then don't go by the history. If someone is giving an indirect observation, then it becomes even more unreliable. At times it happens in front of us, we can't tell. It's a genuine seizure or it's a functional or it's a genuine seizure. It can be, as Rokas said, very, very difficult. At times we are become so confusing. And, best is have pointers. These indicators are pointing towards psychogenic. These indicators are pointing towards genuine seizure in any kind of a presentation. So this will actually help you to learn with time, with experience. You might take your own sides, and you might have your own biases also.
One thing that has helped us a lot lately in this is the videos that the patients are. Because we used to rely only on history. Now, if the patient has a video, so you also ask the patient like next time in the video. That has like clarified a lot of I think confusions in many of us because at times the history was the only thing and you can and the caregivers they don't know what you're asking. And sometimes they will say yes to everything, or they are also emotional still the benefit of time.
This verifying this 2 minutes take and 10 minutes pass.
Yes.
And whether this took 2 minutes,
Yes,
it takes 10 minutes apart. Even that is not easy.
I still remember when I started my residency. So patient came, he आधे घंटे तो होता रहा. And it came down to be genuine epilepsy.
Right.
Patient responded with carbazepine. I asked my senior sir, he was saying half an hour. He say you divide the duration by 10.
Yes.
And they say you 10 times so he come कर दो जो guardian duration बताते.
And then the confusion type part. So for a non-clinical person, it is difficult to differentiate when the seizure started, ended. What was the like aura? What was and the confusion state? They would take that also as seizure.
I think one point I think last point you have rapid post-ictal rehabilitation. So this is because post-ictal confusion, if it is clarified, this is a good indicator.
And sometimes different elegant matches so many things, but different platter. They mentioned pupillary light reflex is so difficult time of
Uh,
and
but actually, we can do pupil light reflex if we sometimes have patient emergency and we have some confusion, then I think we can do it. We don't do
अब
that.
तो मोबाइल पे टॉर्च है
तुरंत देख लेना.
Yes, planters should do. Something that, some things that you can do immediately at that time. To see patients like ward in the emergency. That's something that you can immediately that you should do. Planters with the reflex.
I think personal experience is that if we are going into too much of detail and the interview is getting prolonged and we are asking about a lot of factors, then it is going into a confusing way. In initially few minutes, if you are very clear, you are very clear. It is organic. अगर हमारा इंटरव्यू चलता जा रहा है और हम पूछते जा रहे हैं और मिक्सिंग होती जा रही है, that means कि वो क्लैरिफाइड नहीं.
how difficult can be
और हिस्ट्री मतलब अगर सीरियस इंजरी है, गाड़ी चलाते वक्त आ गया, सीधे थोड़े से छत से गिर गया, सीरियस इंजरी हुआ है, तो मोस्ट लाइकली सॉल्व. वो भी पक्का नहीं है, वो भी नहीं है, कुछ भी पक्का नहीं है, लेकिन मोस्ट लाइकली.
parallel thing from that is what I do want to part of it. It's just follow the brain already. And it is a episode for मतलब कभी तक नहीं हुआ मतलब 3-4 years हो गए we follow that you
Again,
also have to
how to dissociative, like what is in malingering? You actually may know both are dissociative. I've seen a few patients, like I've seen a dissociative super patient develop bed sores because they are like extreme trauma अगर है किसी को जैसे नाम नहीं बोलते हैं, so it is very difficult. Then you start doubting, but the history is there. There is extreme trauma, and after that the patient has gone, no neurologic effect.
and pulling out so many things just
Right.
like that last 2 days.
Like many things that are pointed out, injury, incontinence, etc. Sometimes you see dissociative tongue bite, but that is more important. Tail core side. They dissociative patient also they're going again and again to the doctor, so they pick up the similar questions that they are asking. Then it becomes chronic patient.
And maybe but I also added, though the list was pretty exhaustive of presentation, some pain dysfunctions which present as functional, like the eyebrow sign,
Take one
functional facial palsies.
patient है या फिर depression की वो जो eyes को वो कर देते हैं, बंद कर देते हैं.
We have had very good discussion.
I think she presented very difficult, but it was a logical conclusion to the fail of vaccine is presented. Because if you don't discuss this, it becomes. That is why we thought that we did this.
A very good presentation. I think that you throughout the seminar is good. Well. Just make practice. This is your first. Don't make a habit of writing everything on the slide and bullet points. You can write. You can like see you are presenting cases to us. You don't write the whole history. You just bullet points and speak sentences. Then speak sentences. So you have the keyword bullet point is there, and you can make a sentence. Initial part you just keep you can say print out of what is a slide बनाया उसका print out कर दो और उसके से bullet point हो. So you should be able to speak without it. Okay, so then you can look at the audience and have a better connection. Better you can speak. You can communicate with them. So this is your like first year, okay, but you should have that in mind that I have to do this as a second, third year. That should be your year. That bullet points and speak from yourself.
This is a seminar we have also done few things.
Thank you for that.
अच्छा ओके
Second
सेकंड लगा ना चेंज हो गए अभी इधर में 8-10 सेकंड
extend किया होगा ना जो स्पीड है ना वो उसे डुप्लीकेट किया होगा एक्सटेंड किया होगा जो वो कभी इसमें टेक्स्ट पे आइकन भी क्या है अगर आप स्कैन करते हो तो